So thank you everyone for joining us this evening. My name is Jyoti Nanda. I work with UTIVA, and I also have one of the co-founders here, Faraz. Hey, Faraz. And so before I get started, and Faraz, did you want to say a word?
I was just going to say hi because you paused for a bit, so keep going.
Okay. Before I introduce Dr. Campeau, I just wanted to go through some quick housekeeping for this evening's talk. So the talk is scheduled for about an hour. We're going to be doing about 35 minutes of presentation followed by Q&A. We also have a raffle afterwards, and that's a live raffle. So if your name's called, you're going to need to be there. So make sure you hang on. And then after that, if anybody's interested, I will be going through the UTIVA portfolio of products and answer any questions that you may have. So if you're interested, you can hang on. Also, for any questions that you have, just put them into the chat or the Q&A, whichever you prefer. We'll be logging them, making a list of all of them, and then we'll do our best to get through them at the end. Okay, so with that, I am going to introduce Dr. Lysanne Campeau. So Dr. Lysanne Campeau is an associate professor of surgery at McGill University. She was recruited in 2013 at the Jewish General Hospital of Montreal in the Department of Urology and the Lady Davis Institute for her clinical and research expertise. In terms of her training and background, she completed her medical school and surgical residency in urology at McGill University in 2010. Dr. Campeau then pursued her clinical and research interest in urinary dysfunction at Wake Forest Institute for Regenerative Medicine in North Carolina, where she obtained a PhD in physiology and pharmacology. She completed her clinical training at New York University in an accredited fellowship in women's pelvic medicine and reconstructive surgery. Her specialties are neurogenic bladder disorders and urinary incontinence and pelvic reconstruction. Dr. Campeau is very involved in the scientific community through her participation in organizations such as the International Continence Society and the Society of Urodynamics, Female Pelvic Medicine and Urogenital Reconstruction, also known as SUFU. Dr. Campeau has published over 65 peer-reviewed articles and serves as a reviewer for several journals. Dr. Campeau, we're so excited to have you here with us today.
Thank you so much. Thank you for the nice introduction. So I'm very happy to be here tonight to talk to you about UTIs, and it's a subject that I'm very clinically passionate about because I think there's so many women that can be helped if they're given the proper tools and the proper assessment. So I'm going to move on to the objectives of today's talk is basically how to define and identify recurrent urinary tract infections. And so I'll really focus on recurrent urinary tract infections in women. And so we're talking about the non-complicated one for most of the talk. So then we want to establish the workup and the treatment of these recurrent infections along with prevention strategies. We'll talk a little bit about proper microbial use for the treatment of recurrent infections and identify some of the referral indications for UTIs, recurrent UTIs. So here's the outline. So definition, epidemiology, how to diagnose, when to refer, how to treat, how to prevent, and antimicrobial stewardship. So how do we define a UTI? So urinary tract infection is an inflammatory response of the urothelium to bacterial invasion that usually has along with bacteriuria and pyuria. And so another term for UTI is an acute bacterial cystitis. And so that's a very important point, is how to differentiate. And this is something where you can educate your patients about, is how to differentiate your UTI from just plain bacteriuria, because bacteriuria is the presence of bacteria in the urine that can be either asymptomatic or symptomatic. Now, asymptomatic bacteria we don't treat unless their patients are undergoing surgery or they're pregnant. And so patients automatically think, well, there's bacteria in my urine, it's a UTI. And so it's important to really identify that UTI is an inflammatory reaction, and there's usually pain and there's symptoms. So pyuria is the presence of white blood cells in the urine. So how we differentiate uncomplicated from complicated. namely an uncomplicated can only happen in women. As soon as it's in male, it becomes complicated, and it should be in a non-pregnant, immune competent woman. So that's what an uncomplicated UTI, so with a functionally normal urinary tract. Anything else is considered complicated. Now, recurrent infections are recurrent cystitis, a bacterial cystitis in an uncomplicated form, and it's either 2 culture proven for 6 months or 3 episodes within 1 year. And so that's then, once they reach that, then they're considered to have recurrent infections. Then it's important to differentiate between reinfection and persistence. Reinfection, there needs to be an interval between the 2 infections where there was no bacteria present. So basically a sterile intervening culture present, or more than 2 weeks after treatments. And so then that's considered reinfection. And so sometimes, most of the time, they're different organisms, and that can actually be quite common in women. So that becomes part of the recurrent UTI spectrum. Bacterial persistence is really that the bacteria, it's the same bacteria, same resistance pattern, and it just hasn't been cleared. So usually there's a shorter interval between the treatment and the recurrent infection or the recurrent positive culture, and that can be as a result from a nidus, either a stone or an abscess or diverticuli or different reasons. And so that may be a reason why we want to investigate a little further. Now, what about epidemiology? Well, it's very, very prevalent. UTIs in women over the age of 65 is about 20%. If we looked at the overall population, it's a little less, about 11%, but most adult women, the majority of adult women will have at least 1 infection in their lives. So most women you speak to will know exactly what a UTI is and how to what kind of symptoms they may present. Now, 10% of women between the age of 65 and 85 will have reported a UTI within the last year. So 10% of women within the last year had a UTI. And if we look at over the age of 85, it's 30%. So it's quite high. Now, what about how many of those will actually get recurrent infection, which is the topic of this talk? And so usually after 1 episode or the first episode of UTI, about 27% of them will have a recurrence within the next 6 months. So that falls into the category of recurrent infection. And 2.7% of them will have a second recurrence within the same period of time. So we'll talk about the first, we'll talk about the main clinical case, which is Mrs. J.K.O. I think you guys recognize her. So Mrs. K.O. on this picture actually is a 63-year-old woman. And so she's a woman who's had 5 pregnancies and 4 deliveries, with 1 miscarriage, 1 stillbirth, and the other ones were normal pregnancies and normal births without complication. She had menopause, gender-went menopause at the age of 51. She mainly takes medications for blood pressure and hypothyroidism, and she's had a previous vaginal hysterectomy for fibroids. So she basically comes to see you because she's noticed for the last year she's having infections almost every 2 months, and they're quite symptomatic. They're mainly with dysuria, increased frequency, and some pain that's associated. She's also had some episodes of gross hematuria on these episodes of infections, and she hasn't been able to identify any specific trigger to these infections. So when you're seeing these patients, there's many different things you want to identify. So triggers are important. You want to know if there's any issues with GI aspects. You want to know also if there's any recent use of antibiotics for any medical condition or any other prior antibiotic related problems. So relevant to her, she has an allergy to sulfa, so it's important to keep that in mind. You want to know if there's any associated back or flank pain associated. Is there any vaginal discharge? And if there's an associate with sexual activity, you want to know a little bit more about the contraceptive methods or any kind of hormonal product that are used. There's other UTI predisposing conditions you want to know, like traveling, working or walking for a long time, diarrhea and constipation. Those are all different things. I like to also ask the patients if in between infections they have urinary symptoms. So do they have obstructive urinary symptoms? Is there any sign that could tell me that, well, maybe they're not emptying their bladder properly in between infections? So those are all important aspects to consider. I like to know if they're having like vaginal a bulging sensation, which could suggest a prolapse, pressure, they have any kind of burning or vaginal pain in between infections. So those are all important aspects to consider in your history taking. So the main diagnosis of a UTI starts with symptoms. Usually they'll get burning, so it's an acute onset with some increased urgency, frequency, occasionally some hematuria, and they can also have a new or worsening incontinence. In older women, sometimes it's not as specific in terms of presentation. It could be a lot more subtle. It could be kind of a very gradual and subtle presentation. I had recently had today a patient who came to me because of having a problem with urgency urinary incontinence that had developed over the last few months, and it was very problematic. And we did a culture, it was positive. We treated her, and now she's back to her baseline. She's super happy, but because it was such a kind of a subtle onset, it wasn't as obvious. Now, most of the time, the main culprit, the main pathogen that is identified is E. coli, and about 75 to 95% of the time, and it's identified with urine culture. In order to say that it's an infection, you need to have more than a 10 to the 5th CFUs per milliliter in a clean catch midstream specimen. So this is what you want to get from your patient. If you have a strong suspicion, you would accept a lower CFU count. And I always like to get a urinalysis at the same time as a urine culture. So they kind of go hand in hand for me because then I can it's easier for me to identify whether this is actually an infection or if it's a contaminant. Now, how do infections happen? Well, if we look at E. coli, so the adhesion of E. coli actually in the urinary tract is mainly based on mannose sensitive mechanism. And so it binds to uroplakin and through the type 1 pili that are present here on the bacteria, and it binds to the uroepithelial cell surface and becomes internalized and leads to an infection. Now, other points to consider, I mentioned that I always like to get a urinalysis. Well, the urinalysis will tell me if there's bacteriuria, and so there's different there's different sensitivity and specificity for UTI. Usually it might be non-detectable with the count that's a little lower. And even if I identify bacteriuria in the urine, but I don't see a positive culture, if they're asymptomatic, then I don't worry about it. It could be just a contaminant. Positive nitrites on urinalysis is a little bit more specific for UTI, up to 90%. Same thing for the presence of white blood cells, which definitely would suggest an inflammatory response. Some of these patients may also have hematuria, and again, it goes with an inflammatory response. It might be pertinent in that setting, and we'll talk about it a little later, is to make sure that this microscopic hematuria resolves after the treatment of UTI. And if it doesn't, this would require a urological assessment. So there was a very nice guideline published in 2019. It's the American Urological Association, combined with the Canadian Urological Association, along with the SUFU, which is the Society for Urodynamics and Female Urology. They published a guidelines in 2019 about how patients with recurrent infections should be evaluated. So here it states, basically based on clinical principle, that a complete history and pelvic exam should be done on these patients. To make a proper diagnosis of recurrent infection, you need to have positive urine cultures associated with prior symptomatic episodes. So basically, this stresses the point that a culture should be done. Regardless of the patient, she knows that she has an infection. A culture is essential in identifying the best antibiotic and also to proving that this is actually an infection. So clinicians should obtain repeat urine studies when an initial urine specimen is suspect for contamination, and they may want to consider catheterized specimen in certain situations. In terms of the examination, we'll talk about it during the case, but so the physical exam should include an abdominal and pelvic exam as mentioned. And basically you're looking at the pelvic support for the bladder, You're looking at the urethra, the meatus, the vagina, identifying if there's any significant prolapse. You want to palpate for tenderness, for possible diverticulum or cysts. And you want to identify if there's a presence of vaginitis, vulvar dermatitis, lichen sclerosis, vaginal atrophy. Those are all important points. You may also want to consider where there's a presence of possible neurological conditions as well. In certain patients, you may also want to evaluate whether or not there's a proper bladder emptying if you're suspicious that the patient comments about some voiding difficulty. And so you may want to do a residual, a post-void residual after emptying. So certain things to consider also when you're doing a urinalysis, so we talk about here if there's a suspicion for contamination. So contamination could be suspected if the counts are below 10 to the 5th CFU per milliliters, or if there's more than 2 organisms present, or 2 or more organisms present, that could suggest a contamination. Also, if there's squamous epithelial cells present on your urinalysis, if there's mixed growth, or if there's a lot of lactobacillus on your urine culture, those are all points that may suggest that there is some contamination, and you may want to repeat that culture in that setting. So cystoscopy and upper tract imaging should not be routinely obtained in the index patient presenting with recurrent UTI. And unless there are other presenting symptoms or findings on your exam that would suggest the need for further evaluation, it's not required as routine. So here, clinicians should obtain a urinalysis, a culture with sensitivity for each symptomatic acute cystitis episode prior to initiating treatment in patients with recurrent infection. And this is a grade C level evidence with moderate recommendation. So now let's go back to our clinical case of Mrs. J.K.O. So on physical exam, we identify a small urethral caruncle. It's not bleeding. There's no evidence of a diverticula or a vaginal cyst. On exam, there's no significant stress urinary incontinence. However, there's a presence of moderate vaginal atrophy, and she has a stage 1 anterior wall prolapse. However, upon further questioning, she's not bothered by vaginal bulging, and she feels like she empties well. She has no voiding difficulty. The urine culture that was done shows E. coli that's resistant to Cipro. And the urinalysis showed positive for nitrites and leukocytes along with RBCs. So are there any other investigations needed in this case? And what do we need to do about the hematuria? Do we need to investigate this any further? So if there's hematuria during a context of an infection, I don't worry about it. However, I will repeat a urinalysis once the infection has been treated. The stage 1 anterior wall prolapse doesn't alarm me, doesn't worry me in patients who've had poor vaginal birth is quite normal to identify, and it doesn't need to be addressed necessarily unless she were to have some more voiding difficulty, feeling that she wasn't emptying her bladder. You might want to look into possibly some elevated residual. The vaginal atrophy goes along with a urethral caruncle, and that's something that we should definitely address, and we'll talk about it as you continue the case. Now, are there certain reasons why you'd want to refer this patient? Yes, there are. If, for example, despite properly treating a culture, the bacteria persists, so this is the difference between reinfection and bacterial persistence, that may be a reason to refer, or at least to, or also to further investigate. If a patient had prior surgery or trauma, which suggests maybe an abnormal anatomy to the genitourinary tract. If the gross hematuria or microscopic hematuria persists despite resolution of infection, those are reasons why you'd want to refer. If patients have had previous stones or in the bladder or in the kidneys, that could suggest maybe a possible nidus. If the patient has some obstructive symptoms, we've talked about that. What are those? While straining, weak stream, intermittency, hesitancy, or if on uroflow it's somewhat low and a high residual. Any signs of possibly immunocompromised state are also reasons. So here we talk about urea. If you identify in the urine culture urea splitting bacteria, such as Proteus or Yersinia, that could suggest the presence of stones or nidus. Patients who have repeated pyelo, or patients who have symptoms of pneumaturia and fecal, which is basically passing gas in the urine or passing stools in the urine, which could suggest a fistula and would require referring. Now, what about some principles of antimicrobial therapy? Well, basically, you want to choose an antibiotic that has the highest chance of eradicating the bacteria in the urinary tract. And you want to minimize the eradication of bacteria everywhere else. So primarily in the GI tract and in the vagina. Those are good bacteria. You don't want to wipe out the microbiome from your gut or from the vagina. You want to really just get rid of the bacteria that's present in the urine. And so you want to, the efficacy of these antibiotics is you want to have the highest or at least reach an MIC, so minimal inhibitory concentration above for the proper duration to treat to get rid of to eradicate the organism. And you want to choose antibiotic based on the spectrum activity from your urine culture and sensitivity spectrum. And you should also consider if patients are actually septic, they have a pyelo, well, you actually want to get blood levels of antimicrobial, but this doesn't apply to uncomplicated infections. And if patients have some renal insufficiency, you might want to consider that in your choice of antibiotics. So normally for the first line treatment for uncomplicated symptomatic UTI, those are the three ones that are recommended. So as you can see here, Cipro or fluoroquinolones are not recommended, and I need to stress that as much as possible. Fluoroquinolones, first of all, there's a high level of resistance. E. coli is highly resistant to quinolone, and second of all, these are really, really big guns to treat uncomplicated UTI, which will eradicate all the microbiome in their GI tract, and also has some significant side effect or complication profile with tendon issues, etc. So quinolones should only be considered if patients are resistant to every other possible oral antibiotic. So the ones that we recommend are nitrofurantoin, macrobid, for usually 5 to 7 days, or there's Septra or sulfamethoxazole and trimethoprim, and so that's for 3 days, or 1 single dose of fosfomycin, and that should, these are antibiotics that usually are pretty well tolerated, have low rates of resistance and low rates of adverse events. So we talked about antimicrobial resistance regarding fluoroquinolones, and you can see that the resistance pattern is up to 25%. This is the 2018 source for Quebec. And so you can see it's quite high, while if you look at nitrofurantoin, susceptibility up to 97%, which is pretty good. Septra, there's a little bit more resistance, but it's usually better tolerated, and it's really more concentrated in the urine. And so you have to consider your resistance pattern, at least based on geography, your local geography, basically. So regarding antibiotic treatment, clinicians should offer patient-initiated treatment for certain patients for really select recurrent infections while awaiting for urine culture. So I have some patients that I always tell them, well, you need to do your culture first, send it off to the lab, and you can take your antibiotic as soon as you give a sample. And so the first line therapy, as we mentioned, are the 3 ones based on the local antibiogram. You want to use the shortest duration of antibiotics as reasonable and no longer than 7 days. And that's something that I often point out to my patients, that they may have persistent symptoms even beyond the treatment of their antibiotic, particularly if you're using fosfomycin or Septra, which are short duration, but really the eradication of your bacteria could take a little bit more time. And it's not just the eradication of bacteria, but it's also the inflammatory response. And so the inflammatory response may persist beyond the eradication of bacteria in the urine. And so in some of these patients, I'll recommend, well, if they're still symptomatic, despite completing using the right antibiotic based on their urine culture, then I'll tell them to take some maybe Tylenol or ibuprofen to try to resolve some of the symptoms. And in certain situations, I may repeat a culture if they're still symptomatic beyond a week to 2 weeks, despite taking the proper antibiotics. In some instances where they have recurrent infections with several resistance, you may want to consider parenteral antibiotics, but that's much more unusual. So as I mentioned, to reiterate, you need to get a urinalysis, urine culture with sensitivities before starting antibiotic. Use the first-line treatment according to sensitivities, and self-start antibiotics like patients can be considered for certain patients.
Dr. Campeau, just letting you know, we have 10 minutes to go.
Perfect, thank you.
Cool.
So our patient had some symptom resolution after 5 days of her nitrofurantoin in this case. Now let's talk about some prevention strategies. So normally in patients, I will direct according to their presentation, but there's some general aspects that they can consider. So conservative measures, while definitely the use of increasing fluid intake, which I didn't write here, are very important. You may want to consider some of the whether it's spermicide or pre or post-coital real evidence. Voiding is really, there's not much evidence. Taking probiotics in conclusive studies, and then we'll talk about primarily the cranberry products that can be used and are considered conservative measures. Regarding antibiotics for prevention, really should be kind of the last resort. And there's different ways to go about it. It could be either continuous, self-start, or post-coital. And we'll also talk about estrogen in postmenopausal patient, which is a very important point also to consider. Now, what kind of antibiotic prophylaxis we can consider? You see a few that are listed here. So the trimethoprim, sulfamethoxazole, that can be used either in continuous format or post-coital. And so you see the dosage here. So we'll first start by kind of my last resort to get it out of the way. So what about antibiotic prophylaxis? Well, you may want to have a discussion with your patient about the risks, benefits, and alternatives in some of these patients. The duration has been proposed between 6 to 12 months. And we know that once they stop antibiotic prophylaxis, the rates of recurrent infections come back to exactly how it was taking the prophylactic antibiotics. So that's one of the main reasons why it's my last resort, because it doesn't get rid of the problem. It just kind of pushes it off for a little bit. Now, what about my preferred prevention methods? So there are these non-antibiotic prophylactic measures, and the main one that we have a lot of evidence in the literature about their use are the use of cranberry prophylaxis for women with recurrent UTIs. Now, based on the different literature review, there are different ways that this can be offered to the patients, either with an oral juice. However, the main downside of that is that it's quite high in sugar content. So for patients who may have issues with weight or diabetes, etc., it's not a good option. But luckily, we have tablet formulations, which doesn't have the sugar content. Now, there's the tablet formulations you find kind of the generic ones or the big brand in pharmacies that are basically the 500 milligram cranberry fruit powder. The problem with these 500 milligram daily cranberry fruit powder is that there's no regulation of knowing exactly how much of the active ingredient, which is the proanthocyanidins, which I wrote here, is present in each of these tablets. There's no regulation, or there's no standardization. And so that is not my preferred option. My preferred option is the use of a standardized formulation of these proanthocyanidins. And there's exactly in each dose, there's 36 milligrams of the PACs. And so there's definitely literature about the evidence of their use for recurrent infection. But personally, also, in terms of my clinical experience, has been wonderful with my patients. I've had so much feedback from my patients saying that this really has made a big difference in their recurrent infections, and so and it has very low risk also present. So besides the cost, or besides maybe some patients may have a little bit of gastric reflux, usually very well tolerated. And as compared to the use of antibiotics, which has a lot more side effects and a lot more problems with resistance pattern, that is definitely my preferred method. There was an update to the guidelines that was published in 2019. There was an update in 2022, which showed that a high-dose cranberry, along with lactobacillus and vitamin A, had less UTI recurrence compared to placebo. So again, added evidence in the updates to the guideline that were present. Right. So how do PACs work? Well, basically, proanthocyanidins will bind to the E. coli, so bacteria. You see, you have these P. fimbria. We had talked about it a little earlier, how the E. coli will bind through a mannose specific mechanism. And so by having these PACs binding to the fimbria, well, the bacteria can no longer bind to the uropithelium. So it prevents, by having this a similar shape to the mannose insensitive glycolipid receptors on the urinary tract, these PACs will adhere to the fimbria and prevent these bacterial adhesions and then promote natural flushing. So basically, by having these present in the urine, it prevents adhesion to the uropithelium. So there's different, as we talked about, there's different formulation. So these are the big brands. You have these Jameson, Weber, that are advertised with 500 milligram of cranberry. Now, when they were analyzed in terms of identifying how much of the PACs is present in each of these formulation, there was much less standardization, and it was much lower, as you can see, compared to the Utiva formulation, which is a lot more standardized, a much higher dose of PACs. And when you look at the anti-adhesion score, so basically the lower the score, the better. This was quite low compared to other formulations, which was much higher, or basically had no significant effect on adhesion. Okay. Now, other prevention strategies that we can offer patients while increasing water intake, and there was some evidence in the literature in both premenopausal, well, I'm mainly in premenopausal patients. There was a good study on that, but I think we can extrapolate the results to our postmenopausal patient. The probiotic lactobacillus, there's less evidence about it, but again, very minimal side effects, and can be, it's just mainly a cost issue, but can be beneficial for some patients. Other supplement, well, there's D-mannose. We had talked about how E. coli binds through a mannose-sensitive binding process. Now, D-mannose it's a monosaccharide, it's a sugar that's found in fruits and berries, and also cranberries. And it's also synthesized in the body from glucose for the synthesis of glycoprotein. And so D-mannose, it can be helpful to prevent infection through a certain mechanism, shown in the other slides. So it also binds to the type 1 Fimbria E. coli, and it therefore inhibits bacterial adhesions to the urothelium. So it saturates the fimbrial structures on E. coli, and so it's basically a competitive inhibition that's present as a potential mechanism for preventing UTI treatment. So when it's present in sufficient amount, it basically binds to the E. coli fimbria, preventing it from binding to the urothelium. So it's a similar idea as the PACs. And there's another prevention or supplement that can be considered is methenamine. Basically, methenamine, once metabolized, becomes formaldehyde and ammonia in an acidic environment in the urine. So there's different salt formulation of methenamine, either hippurate or mandolate. Basically, this is an antiseptic. It's not an antibiotic. And so there's really no risk of resistance formation for this type of supplement. So it has little antimicrobial activity in an alkaline environment, but primarily it's very helpful in an acidic environment. So some patients will also use it combined with ascorbic acid to further acidify the urinary environment. And there was in the recent update, there was no difference between the use of methenamine or antibiotic for the prevention of infection. So it might be an interesting thing to consider. Now, a very important point is also estrogen. And so this is primarily in the peri, so patients who are undergoing menopausal or the postmenopausal women with recurrent infection. Estrogen is actually probably the #1 thing that I prescribe my patients. For most of my patients, I have a large population of postmenopausal women, and so many women can benefit from the use of estrogen for different reasons, but one of the indications for it is actually recurrent UTIs. It works very well, and in our patient, as we discussed, there's other reasons. While she has vaginal atrophy, first of all, she has a urethral caruncle, and she has recurrent infection, so she has kind of a triple indication for the use of vaginal estrogen, and it has been shown in many in the literature quite strongly how it reduces the risk of future infection, and there's really no issues with bacterial resistance, obviously, as this doesn't lead to any resistance formation. There's different ways to give it. It could be either with a tablet, which is Vagifen is the commercial name, and so this is applied every day, every night for 2 weeks, and then twice to two to 3 times per week. There's a ring that can be placed and changed every 3 months, or there's different creams. There's either the Premarin, which is the conjugate equivalent estrogen, or there's the estradiol formulation, which is estragen, ESTRAGYN. So again, I use this very often. And how it works is basically with the lack of estrogen, there's a process of alkalinization of vaginal fluid. And so this is kind of what naturally occurs. And when the vaginal fluid becomes more alkaline, while bacteria binds a lot better to the epithelium, which is not what we want. So the idea is that you want to get the vaginal fluid or your vaginal milieu more acidic, and basically the way that can be done is by using estrogen, and so which will help colonize the milieu with lactobacillus, and so the lactobacillus keeps the vaginal pH low. So it's you want to have more lactobacillus in the vagina, and that can be done by the use of vaginal estrogen. And so as we talked about, the lactobacillus basically helps to convert glucose to lactic acid, and the lactobacillus present will prevent overgrowth and binding of pathogenic bacteria. Important points: vaginal estrogen has not been shown to increase risk of cancer recurrence in women with a personal history of breast cancer. So I often use it. I like to have the blessing of their oncologist, because I think patients will feel more secure about that. And so there's a lot of evidence showing that it's safe. It does not increase endometrial hyperplasia or endometrial cancer risk. So again, should be used for most patients. What's the best way in terms of antimicrobial stewardship, how to use antibiotic in the best ways possible? Well, you want to obtain cultures for each symptomatic episode. And so you want to tailor your treatment based on your culture, reduce inappropriate treatment, decrease broad spectrum antibiotic use like the quinolones, etc., and to use the shortest effective duration. And the local antibiogram will be very helpful to do that, with choosing antimicrobial with the least impact on normal vaginal and fecal flora. So nitrofurantoin, fosfomycin, sulfamethoxazole, those are all good antibiotics to use. So we'll finish off with our case. So Mrs. J.K.O, she started primary supplements with PACs. She started vaginal estrogen applications. She's increased her fluid intake. And since she was a reliable patient, we started her on possible self-start treatment after giving a urine culture. And 6 months later, she's had absence of UTIs, so drastically improved. So to finish off, some take-home points. And uncomplicated, so recurrent UTIs are uncomplicated infections that are either 2 symptomatic culture-proven infections in 6 months or 3 in a year. You should treat these cystitis or these UTIs with either of the 3 antibiotic listed here. But you should also consider prevention strategies, first with the non-antibiotic options, which include PACs, cranberry supplement, or vaginal estrogen. And in the last case, you may want to consider some prophylactic antibiotic regimen, either low dose or postcoital. And there's certain instances where you may want to consider referring to a specialist, particularly in context of bacterial persistence, or if there's other possible diagnosis or complicating factors. I'm all done. Thank you. Thank you for your attention.
Thanks so much, Dr. Campeau. Let's move on to the Q&A. We have tons of questions that came through. So we'll do our best to, or Dr. Campeau will do her best to get through hopefully most of them. So the first question here is, what if someone has simple UTI symptoms, urine dipstick positive for leukocytes, blood, but urine culture is negative?
So there are false negative. Now, if your urinalysis is strongly positive, or where there's bacteriuria, there's leukocytes, there's blood, those are all highly suggestive. If you have a negative urine culture, again, it could be a false negative. In this instance, you might want to empirically treat with any of the 3 antibiotics if the patient also has significant symptoms. And then following treatment, you may want to repeat another urinalysis just to make sure that this was indeed an infection that was treated. That would be my approach.
Okay, thank you. Okay, so patient was treated with macrobid and symptoms resolved. What does this mean? Female patient, no flank pain or fever?
Well, macrobid or nitrofurantoin is a very good antibiotic. It's part of the 3 listed that are recommended. And so if the patient had a symptomatic UTI and responded to 5 days of macrobid with no flank pain and a positive culture, this would be the appropriate way to manage it.
Okay. Let's see here. Is a reinfection more than 2 weeks after treatment initiation or completion?
I'm sorry, could you repeat?
So to consider an infection as a reinfection, would this be more than 2 weeks after the treatment initiation or treatment completion?
So it's usually treatment completion.
Okay. So what is your approach to patients who believe that they have a recurrent UTI, but the referring physician has failed to do even basic investigations to prove this? No urine culture or even a urinalysis, just giving antibiotics.
So unfortunately, that occasionally happens. And so in that situation, sometimes I start from scratch, right? If I don't have any culture-proven UTIs, but the patient really reports having symptoms that are consistent, well, basically, when she starts with my care, I tell her that my approach is to do cultures, and so, but I will rely on history. So we still do the prevention strategies, and if they've developed infection despite the prevention strategies, then also always do cultures.
Okay. So is treatment required for an asymptomatic patient with a urine culture growth of E. coli?
No, so this is considered an asymptomatic bacteriuria. So there's 2 instances where you want to treat asymptomatic bacteria. The first one is in a pregnant woman, and the second one is if a patient is going to undergo a surgery, primarily genitourinary surgery.
Okay. So when would you prefer Utiba cranberry packs to standard antibiotics for prophylaxis?
So I always favor prevention strategies with non-antibiotic first. So basically all the non-antibiotic prevention strategies, which includes cranberry supplements, there's the D-mannose, there's methenamine, and then there's increasing fluid intake, and there's vaginal estrogen. These are all my non-antibiotic tools that I always will prioritize before going on to antibiotic prophylaxis, because I mentioned the antibiotic prophylaxis helps while they're on it, but as soon as they get off of it, they'll have recurrence of the infection just as much as they had it before. So it doesn't really treat the issue. It just kind of puts a plaster or a Band-Aid, sorry, on their issues. Then the problem comes right back. While my other prevention strategies, for whether vaginal estrogen or Utiba, will keep things at bay without patients developing resistance and all the other possible adverse events that can come from use of antibiotics.
Okay. So we got a couple questions come in regarding the benefits of eating dry or fresh cranberries.
Well, the patients would need to eat a lot of them. So they need to be basically nibbling on the cranberries all day to get the proper dose of the 36 milligram of PAC, which has been shown as the the most efficacious dose to prevent bacterial adhesion. So if patients like eating cranberries, by all means, there's definitely a sugar content that should be that is not negligible, but I think it's important to inform my patient that that's not sufficient.
Okay. How can you reduce painful urination in a acute UTI?
So, I mean, I primarily used to treat it with the proper antibiotics, so that will prevent the painful urination, or what we call dysuria. In some of these patients, I'll recommend using, so drinking a little more, diluting the urine as much as possible, and maybe considering some anti-inflammatory agents like acetaminophen or ibuprofen.
Okay. Can you talk about the safety of Utiva or D-mannose in patients post-liver transplant on cell, sept, or immunosuppressants?
On cell sept or immunosuppressants, I'm not aware of a contraindication of using PACs with any drug in particular. I may be wrong, maybe Faraz could comment about that, but I'm not aware of any drug interaction with cell sept or with other drugs, or in the context of liver failure.
Okay. Let's see here. So if the culture is still positive after 1 week of course of antibiotics, should they continue on the same antibiotic or move to a different one?
No, so if they've taken an antibiotic that was geared towards properly towards the culture that was positive, and after completing the antibiotics, you do another urine culture, and we don't routinely do that for uncomplicated UTIs. It would only be in a context where patients are still symptomatic. So if the culture is still positive, so while you want to think, is this a reinfection? Is it a persistence? If it's the same bacteria with the same resistance pattern, then that suggests a persistence. And so giving the same antibiotic as you did might not do the trick. You may want to consider a different antibiotic, but most importantly, you need to figure out why the infection wasn't cleared. So you may want to investigate further with imaging or refer to specialists.
Okay. Do you take cranberry at the same time as the antibiotics or after?
So there's no issues of taking it at the same time. A lot of my patients take it at the same time. They'll take their PACs with their Utiva and the same day. And sometimes they kind of double the dose when they're having an active infection. And it can actually, there's some evidence that show that combining PACs along with antibiotics has increases the antimicrobial activity of antibiotics.
Okay. So a pregnant patient with asymptomatic bacteria in the urine culture, pregnant patient with asymptomatic bacteria, urine culture persistent lactobacillus. What is the antibiotic option?
So pregnant patient with asymptomatic bacteria with lactobacillus. Well, lactobacillus is usually a contaminant. And so you may actually want to check what your urinalysis shows. Now, there could be presence of squamous epithelial cells. There could be showing contamination, mixed growth. So if it is a contaminant, you may not necessarily want to treat it right away. You might want to repeat your culture and make sure that it's a midstream clean catch sample to rule out that this is a contaminant.
Okay.
But ultimately, you know, if this is persistently present despite the proper catch, well, you might want to treat it. But lactobacillus is not a bad bacteria to have.
Yeah. Okay. Do you ever recommend Cytoplus for dysuria?
If I recommend what, sir?
Oh, I think they meant Cystoplus for dysuria.
Not in the context of infection, no.
Okay. Is there benefit to using cranberry with catheterized patients?
So catheterized patients who catheterize, either they have an indwelling catheter or do self-intermittent catheterization, they go into more the complicated UTIs, they're not uncomplicated. recurrent UTIs. And in this context, definitely we know that taking prophylactic antibiotic doesn't work. Now, regarding Utiva or using PACs or cranberry supplements in these patients, I occasionally do it because we have limited options to offer them. And I know that it's usually very well tolerated and there's low risk of developing resistance to antibiotics. So now we don't have strong evidence in this population, unfortunately, to suggest its use, but several patients just sometimes feel at a loss. They have very limited options. So that sometimes could be an option to consider.
Okay, thanks. Next question, how long after treatment would you advise to repeat urinalysis in patients with hematuria?
How long after treating an infection do we repeat a urine sample for hematuria?
Yes.
So I'd like to have a bit of a timeline. I'd like to at least have 2 to 4 weeks after resolution of their symptoms. I don't want to do it too quickly because then I don't want to have a false positive. I like to make sure that when I do the urine sample, that they are indeed asymptomatic, and I do a urine culture at the same time, make sure that they don't have any persistent bacteria despite maybe some resolution of their symptoms. And if there's persistent microscopic hematuria, I will investigate it further.
Okay. Can you comment on post-coital prophylaxis?
Post-coital prophylaxis. So post-coital prophylaxis is primarily antibiotic prophylaxis, or you can also consider PACs and cranberry post-coital prophylaxis. Some patients may not necessarily want to take Utiva every day, but they notice that if they take prophylactic PACs in a context of a known trigger, so a known trigger could be sexual activity, but there's other known triggers, and some of my patients, they say, well, every time I go to spinning class, I get issues with an infection. Every time I travel or I take a plane, I have issues with infection. So those are identified known triggers, and so in that context, they can either take PACs or antibiotics. The antibiotic prophylactic dose is usually a low dose antibiotic, so it could be either 50 milligrams of nitrofurantoin, it could be a one single strength sulfamethoxazole trimethoprim tablet, and so those are the two ones that I will favor in terms of post-coital or post-trigger prophylactic.
Okay, thank you. Is there a use for N-acetylcysteine supplements for prevention of UTI?
The evidence for N-acetylcysteine is not as strong as the other supplements, and so it all comes down to in terms of tolerance to these supplements, the costs, and the benefits. Right, and so it's not part of my recommendation in general. But again, some patients have seen some improvement, and if it works for them, that's fine. I don't have any issues with that.
Okay. So next question is a bit of a case, so I'll just read it out. So do you do anything different on patients with DM2 on SGLT2 inhibitors? They always have high concentrations of sugar in the urine. Many times the CS are positive for bacteria. In my practice, about 20% are asymptomatic, and sometimes they can have complicated UTIs, especially elderly females. Is there any evidence on what the best practice is in this patient group?
So the question is regarding the SGLT2 inhibitors, which are the new drug categories for the treatment of diabetes. They've become quite more commonly used in this population, and patients who have diabetes, who are somewhat immunocompromised, maybe they have a lot of comorbidities or are at risk of infections, indeed. Now, the SGLT2, even though we know these drugs, they work in diabetes by increasing the excretion of glucose through the urine, and so there were some concerns with having higher rates of urinary tract infection. The literature seems to say that that's not the case, or at least not significantly so. However, I would have to say that my clinical experience is the opposite. I have some patients that really identify a pre-SGLT2 and a post-SGLT2, and I have some patients who develop recurrent infection after starting that drug. I have some patients who also have developed the most balanoposthitis, so infections of the glands of the penis following the use of that drug. So I think I think you have to sometimes individualize your management. Now the question was, what exactly regarding to that drug?
Well, basically that they're saying that these patients, basically what you said, they have high concentrations of sugar in the urine, and many times they're positive for bacteria. He or she is just wondering, for elderly females, what's the best practice for UTI prevention?
Yeah, so just if you identify, again, asymptomatic bacteria is not a reason for treatment with antibiotics. Even in the elderly population, we know about 30 to 40% of postmenopausal women will have asymptomatic bacteria. So again, I would only treat if they have associated symptoms. So if you identify a positive urine culture with symptoms, in that instance, I would treat whether or not they're on SGLT2 inhibitors. If you notice that they're having a lot more recurrent infection on SGLT2 inhibitors, you may want to discuss with the prescribing physician of that drug whether maybe alternatives could be considered.
Okay, and we're gonna do one more question. I mean, there's so many, but I'm just gonna pick one more. This looks like a good one. Is there a counter effect with diabetic patients using D-mannose? Which dosage would it be problematic?
So D-mannose in diabetes, there's the dosage recommended is the standard one. That doesn't even though it's a sugar, it's not a sugar. It's not a, how do you say, it's not a dose that will increase their glucose intolerance by any means. And so there's no dose adjustment, at least not that I'm aware of.
Okay, so then in terms of patients with diabetes, pretty safe then for them to take the regular, like 2,000 milligram dose.
Yeah.
Okay, great. Okay, well, we're going to end the Q&A. I wanted to thank Dr. Campeau for a great presentation, and you really dove through all of those questions with great answers. So thank you so much for your time. Great presentation, and yeah, we're so happy to have you with us this evening.
Great, thank you so much.
Thank you, Dr. Campeau. We'll see you next time.